Okay.
Webcast started. All right.
Wonderful. Welcome, everyone. My name is Molly Mitchell, and I am the manager with the Mid-Atlantic Public Health Training Center here at the Johns Hopkins Bloomberg School of Public Health. And on behalf of the Training Center, as well as the Maryland Department of Health and Mental Hygiene, I'd like to welcome everyone to the July 2012 Public Health Practice Grand Rounds on the Supreme Court decision, What It Means for Healthcare Reform. And I just have a few quick announcements, especially for those of us who are joining us online. If you could just please take a minute to sign in, that way we can let our federal funders know that there were indeed people out there watching us today. Also, we will have an evaluation that we ask you to fill out afterward as well. And for those of you watching online, you can send in an email question to either of our presenters at any time during the webcast or after we're done, and we will have an opportunity for those Q&A afterwards. And also, since you are on our website, go ahead and look around. We do have some archives of previous Grand Rounds on there, and we also have some upcoming face-to-face trainings, including community assessment and formative evaluation, which is coming up on July 26th. So with that, and also I want to just send out best wishes for a quick recovery to Carolyn Quitrocki, who was going to join us today, but was unfortunately not able to due to a medical emergency. But we are really thrilled to have two presenters with us today, Dr. Brad Herring and Dr. Lisa Dubay. Dr. Dubay will be joining us by phone and online. So with that, I'm going to be going ahead and I'll introduce both of our speakers. We're going to be starting with Dr. Brad Herring, who is an associate professor in the Department of Health Policy and Management here at the Johns Hopkins Bloomberg School of Public Health, and is the director of the PhD program in Health Economics and Policy. His research focuses on a number of economic and public policy issues related to private and public health insurance coverage. He has published articles in the Journal of Health Economics, Health Affairs, and the New England Journal of Medicine, and is co-author of the book Pooling Health Insurance Risks. His research has been funded by the Robert Wood Johnson Foundation, an organization of economic cooperation and development, U.S. Health and Human Services, ASPE, and AHRQ. Dr. Herring earned his PhD from the Wharton School at the University of Pennsylvania, received a 2-year Robert Wood Johnson Foundation Scholars in Health Policy Fellowship at Yale University, and served for a year with the White House's Council on Economic Advisors. We also have joining us today Lisa Dubay. Dr. Dubay is a senior fellow at the Urban Institute, where she recently returned after being an associate professor at the Johns Hopkins Bloomberg School of Public Health and a special advisor in the Office of the Assistant Secretary for Planning and Evaluation. Dr. Dubay is a nationally recognized expert on the Medicaid and CHIP programs. She is a health services researcher who has focused on evaluating the effects of public policies on access to care, healthcare utilization, health outcomes, and health insurance coverage using quasi-experimental designs. Dr. Dubay's evaluation work has included assessing the impacts of expansions in public health insurance programs for children, pregnant women, and adults for federal agencies and major foundations. She has also assessed the impact of the movement to Medicaid managed care on access to care and health outcomes. And with that, I'm going to hand the floor over to our first speaker, Dr. Brad Herring. Thank you.
Okay, so thanks a lot, Molly, and thanks a lot to all of you for coming, and for those of you who are watching on the webcast, either at home or in your office. So I'll start off with an apology. Yeah, so I'm not Carolyn Quitrocki. I know lots of you, including myself, are really looking forward to hearing her presentation, but Lisa and I will try and step in the best we can. So what we'd like to do really is talk about Supreme Court decision. But first, maybe I'll give a real quick overview of the Affordable Care Act, right? So years later, there's still a lot of public misperception and confusion about what it does do and what it doesn't do. So I'll do a real quick overview of the ACA and then turn to the recent Supreme Court decision. And so really, everything was really focused on the individual mandate. Is it constitutional? Is it not constitutional? If it's unconstitutional, why? What does that mean for the rest of the ACA? And so I'll talk about that, but then I'll also talk about the Medicaid ruling, right? So this thing was really going under the radar screen. Every bit of the discussion really focusing on the individual mandate, and then boom, we get this decision that affects the Medicaid expansion. So what I'm going to try and do is set the stage and talk about what these rulings said and say a little bit about what they might imply, but then really kick it over to Lisa, who's on the phone, to do a lot of the heavy lifting and talk about the potential implications of this specific Medicaid decision. Okay? So with that, let me give a real quick brief overview of the ACA. Okay, so the main thing the ACA is trying to do, it's really like a 2,000-page law, but at its heart, it's really trying to cover the uninsured, and it's going to do that through two mechanisms largely. So about 60 to 65% of the uninsured are being covered by either a Medicaid expansion. So Medicaid is a public program largely for low-income families. Eligibility is going to expand kind of like across the board to cover largely childless adults in a way that I'll describe in more detail later with what I think is a pretty neat chart. But this Medicaid expansion for the poorest people is covering about half, a little bit more than half of the uninsured covered by the ACA. The other half going to be covered by private health insurance, with the bulk of them getting subsidized coverage through new state-based health insurance exchanges. So a health insurance exchange is supposed to reform the marketplace for individuals and small businesses in a way that hopefully makes it more transparent, easy to choose across different options, but also winds up subsidizing a portion of the premium through a tax credit for people between 133% and 400% of poverty. At least this was the original design, and I'll kind of return to this a little bit later with some of the nuances for what the Supreme Court decision implies. So covering the uninsured through these two main mechanisms, coupled with new reforms to prohibit health insurers from using chronic health conditions when tailoring premiums or even deciding whether to sell a plan. And so in the insurance vernacular, this is referred to as community rating and guaranteed issue. And it's actually adjusted community rating in the sense that premiums will be allowed to vary with age and then also smoking status. But the main thing here is that an insurer's ability to use chronic health conditions done with in 2014. Okay, so then the follow-on to that is like, well, once you do that, then you have the potential concern of quote-unquote adverse selection, where healthier people are less likely to join the pool, sicker people more likely to join the pool. And to counterbalance that, that's where the individual mandate comes in, right? So really essentially trying to penalize people, particularly the young healthy people, if they have some kind of incentive to lack coverage. And there's also an employer pay or play mandate as well. But that's really like the bulk of it, right? So the ACA, as mentioned, huge law, lots and lots and lots of different provisions. But if you really want to focus on the core, that's it. And so essentially what these two charts show is the likely effect of the ACA. The pie chart on the left shows what health insurance coverage would likely have looked like in 2019 in the absence of the ACA, right? So you could also envision that, maybe this is the way health insurance would look if Republicans are successful in repealing the ACA without a subsequent replacement law, okay? So if you kind of compare the pie chart on the left to the pie chart on the right, and let's kind of work clockwise starting at Medicare. Medicare, the program for the elderly, not really changing in terms of who's covered, right? But Medicaid, this is a big Medicaid expansion, as I mentioned, roughly increasing the number of non-elderly people covered by Medicaid by about 50%. The number of people, proportion of people covered by employment-based health insurance coverage, not really changing in terms of the overall number, but there's expected to be a lot of migration both in and out of employment-based coverage in terms of some employers dropping coverage and other employers starting to offer coverage. Okay, so the big thing to kind of focus here on is the reduction in the uninsured from approximately 16% of the population down to 7%, right? So in some sense, this certainly isn't giving us universal coverage. It's really giving universal access. Maybe, there's lots of quibbles about whether it's truly going to yield affordable premiums. Probably left for, maybe the questions or even like another presentation or whatever. But then, the other thing to kind of pick up on here is these new exchanges that I mentioned, right? So if you think about this reduction of the uninsured from 16 to 7%, some of them getting coverage through the Medicaid, as you see that portion of the pie chart increase, and some of them gaining coverage through these new health insurance exchanges, which offer subsidized private coverage, okay? So how do you pay for this thing? So this is a chart from the Congressional Budget Office that essentially, the Congressional Budget also came up with those estimates of changes in coverage that I showed on the previous slide, but they're also the ones kind of tasked with quantifying the dollars here. And so on the upper portion of this chart is the money going out largely to subsidize coverage, right? So the dark blue bars, essentially federal money spent on the Medicaid expansion, and the tax credits for people in the exchange. So a lot of money going out, roughly almost $1 trillion over this 10-year budget window. And it's being paid for essentially by a combination of other federal spending reductions shown in medium blue and tax increases shown in lightest blue, right? So the tax increases, high income people paying more for their Medicare taxes, a number of taxes levied on the different industries, and so on. That's a portion of what's covering the expansion. The other portion is essentially largely a lot of reductions in spending by the Medicare program. Okay, so all right, so there's your primer for the Affordable Care Act. Hopefully this was a review for the majority of you, but for those of you who are just kind of getting new to this or trying to catch up, hopefully that gives you kind of the overview of the ACA. Okay, so let me now turn to covering the Supreme Court decision again before eventually turning it over to Lisa to talk about some of the implications for states, largely with respect to the Medicaid program. Let me first focus on the individual mandate, and I'll kind of try and tell this story about how this constitutionality case developed over time. Okay, so a starting point is maybe to say, well, okay, when Democrats, and if you didn't realize, this was a largely or exclusively Democratic passed law. As they're crafting these things, making tweaks, all this kind of stuff. Interestingly, a CNS News reporter asked Speaker Pelosi before the ACA passed, where specifically does the Constitution grant Congress the authority to enact an individual mandate? And Speaker Pelosi's response, are you serious? Are you serious? Right, so not just once, but twice. 2 are you seriouses. Okay, so fast forward a little bit in our story with respect to constitutionality. ACA passes March 2010, and about 10 months later, well, I guess no more, like 10, 11 months later, a bit of like a news kind of like shocked everybody. This judge in Florida, Vinson, forgot his first name, basically like rules that the ACA should be struck down in its entirety, right? So he basically said, look, the individual mandate is unconstitutional. And because the individual mandate is so intertwined like a clock with the whole rest of the ACA, the whole thing ought to be struck down, okay? And when that happens, a lot of health policy analysts, a lot of advocates start to kind of say, well, gosh, maybe there's something going on here. And over time, a lot of the decisions from these judges were essentially pretty partisan, right? So the Democratic-appointed judges voting in favor or ruling in favor of the ACA, Republican-appointed judges ruling against it. And so that kind of got people starting to think, well, yeah, maybe this is going to go to the Supreme Court. Okay. So a little pause in our story. I like referencing InTrade a lot, so I don't know if how many of you are familiar with InTrade, but it's basically a website in Ireland that allows people to bet on certain outcomes, right? So many people refer to this as like speculative markets, right? So you can bet on the outcome of the Oscars, you can go and bet on the outcome of the November election, and you can go and bet on what you think the outcome, or you could, over the past several years, couple years, bet on what you thought the outcome of the Supreme Court ruling would be, okay? And so the thought process here, I guess particularly for an economist like myself, is to say, well, look, if people are betting and placing, money on these outcomes, then perhaps the price of this asset, if you will, should kind of reflect the probability of this event actually occurring. Okay, so if you follow that, if you're down with this notion of InTrade being representative of what the probability may have seemed to be, at this point in time, you kind of get like about a 40% chance that the individual mandate might get struck down. So this is kind of focusing on the left-hand side of this chart. Okay, so after Judge Vinson rules that it's unconstitutional in striking down the whole ACA, 11th Circuit Court of Appeals rules that the mandate is unconstitutional, but the rest of the ACA could hold. And again, this kind of set this path where everyone was kind of like, it's probably going to get heard by the Supreme Court. The day that the Supreme Court agrees to hear the case that is brought forward by 26 states led by Florida and the National Federation of Independent Business, InTrade, again, if you put like a lot of stock, pun intended, InTrade, the probability, of the people who, betting their money on InTrade, that the mandate might be struck down, jumped a little bit from 35% at the opening bids to 44% at the close the following day. Okay, so kind of moving forward in our story chronologically to the right, you have this historic court case in front of the Supreme Court, 3 days, right? So kind of unprecedented that it goes 3 days. Day one kind of dealt with some technical issue about whether we can even look into this thing due to no one having actually paid the penalty yet. Kind of boring stuff. Day two was really about, is this mandate constitutional? Day three is kind of tackled the severability issue in terms of the connection with the rest of the ACA. And the Medicaid expansion, again, the Medicaid expansion kind of floating under the radar, but we'll circle back to it in a minute. And, by all accounts, that day two of the Supreme Court hearing did not go well for the administration, right? So a CNN news reporter, right afterwards, came out and said it was a train wreck. If you listen to the audio, which I did, it's kind of entertaining, but Solicitor General for the U.S., Varelli, he's kind of stumbling on his words. He's coughing, whereas Paul Clement, bringing the suit, he just sounds awesome, right? He can sell me whatever, the proverbial selling an igloo to a bunch of Eskimos, right? He just sounds awesome, right? This guy, yeah. So anyway, boom, day two, the story, the narrative here is oh my gosh, the individual mandate's in a bit of trouble. And so if you kind of keep thinking about, looking at InTrade over time, you can see it, moving upwards, approaching 75, 80%. The day comes and CNN, speaking of CNN, mandate struck down, right? So in some sense, this narrative, everyone was kind of expecting it. And as you read through the abstract really closely, some of the initial language makes it look like it's not really good for the individual mandates. I've kind of labeled this the Dewey defeats Truman moment for CNN. I could probably spend a little bit of time talking about what this means about the media and the rush to say, oh yeah, well we reported at 10:15, whereas our competitors reported at 10:16. I won't. And really kind of just look at the details here. Okay, so again, it's a bit of surprise because everyone's kind of expecting the mandate to be struck down. And now kind of turning to some legalese, right? So the big argument about the Supreme Court being struck down was largely centered on the so-called Commerce Clause, right? So Congress has the ability to regulate commerce, interstate commerce. And so the big catch here was, well, can you actually compel somebody to enter into commerce, right? So is a person who doesn't want to purchase health insurance coverage, are they in the market, right? And so then there was a lot of discussion about, well, look, there's the healthcare market, there's the health insurance market, they're related, but somebody receiving uncompensated care, that's really the healthcare market, not the health insurance market. In some sense, a lot of like esoteric arguments, legal arguments, how many angels can dance on the head of this pin? But ultimately, yeah, the Supreme Court said, as far as the Commerce Clause goes, a majority of us think that the Commerce Clause does not apply. And in turn, as you're going through the abstract, that's kind of the first thing you read. And so the CNN producer's like, oh my God, the Commerce Clause, it didn't hold. Oh my gosh, let's get this out there. It's struck down. But if you keep reading, to the next page, or actually on that same page, they say, well, also, the necessary and proper clause doesn't apply. And so some key quotes here from the ruling. Respect to the Commerce Clause, the framers gave Congress the power to regulate commerce, not to compel it. With respect to the necessary and proper clause, a key quote here, even if the mandate is necessary to the ACA's other reforms, and this is kind of the guaranteed issue community rating stuff, it is not a proper means for making these reforms effective, okay? So then, I think this is where Judge Roberts, either to your dismay or your pleasure, depending on your political persuasion, pretty much came and said, look, all this discussion about the Commerce Clause, necessary and proper clause, yeah, maybe this is interesting from a legal perspective, but at the end of the day, this is really a tax. That's what it is. It's a tax on people to cover their uncompensated care costs if they don't purchase health insurance coverage. And just because President Obama didn't want to call it a tax and explicitly said, no, this is not a tax to George Stephanopoulos, right? Just because there's all this political posturing about whether it's, Democrats being averse to calling it a tax, I think Roberts just basically said, look, it's a tax. It's a penalty that's paid through the tax system. No one's going to be hauled off to jail for not purchasing health insurance coverage, right? So really, at the end of the day, it's a tax. And so Roberts, ruled with the progressive side of the court, saying mandate's constitutional under the Constitution's taxing clause. Okay, so interestingly, right? So kind of going back to the conventional wisdom and the narrative that was kind of leading up to the Supreme Court case decision, everybody was really, really focusing on Kennedy, right? So Kennedy's the moderate, the swing vote. What's he going to do? Is he going to go with the conservatives? Is he going to go with the liberals? Everybody fixated on Kennedy. And interestingly, the swing vote actually swung to the right. And not only did Kennedy believe that the mandate should be struck, he actually in turn said that it shouldn't be severable and that the whole ACA should go down, right? So what's kind of amazing in some sense is everybody thought Kennedy was the real decision maker here, and that Roberts would go with the majority, go with Kennedy. That's essentially not what happened, right? And so in their dissent, key phrase here at the very, very end, for the reasons here stated, we would find that the act invalid in its entirety, right? So in its entirety is kind of key here. So there's also a lot of speculation that Roberts initially sided with the conservatives, and they started working on writing an opinion that would have struck down the whole ACA. And part of the clues there that the dissent appears to kind of be written like it's the decision. They refer to the Ginsburg dissent, apparently. So some instances where people are kind of think, yeah, gosh, it kind of looks like Roberts changed his mind midway through. And the narrative that's kind of come out after the fact is that, well, yeah, maybe Roberts is really just thinking about the long game of the credibility of the Supreme Court. and concerned that overruling the ACA in its entirety would just be really, really problematic for the country, right? And in there kind of had this kind of key interesting quote that a lot of these issues aren't really for the court to decide. It's really about voters to decide what kind of laws they want passed and not passed. Okay. So that's the quick blurb, maybe not so quick from your perspective, on the constitutionality of the individual mandate. Let me now turn to the ruling on the Medicaid expansion. And interestingly, again, I'll say again, stress again, this was totally flying under the radar, right? So the Supreme Court was hearing 4 different aspects with respect to the ACA, and it was the individual mandate that really had all the focus. And no one really thought that this Medicaid complaint, if you will, was gonna really go anywhere. Okay, so to try and help explain the Medicaid implications, or kind of set the stage, and to try and understand the Medicaid implications, let me start with a very busy, complicated chart to try and give you a sense of what the Medicaid program kind of looks like today, and how it's going to change. Okay, so we've got a chart here. Every circle here on this chart is a state in terms of its eligibility for the Medicaid program. And so on the y-axis, going up and down, we've got income with respect to the federal poverty line. So the poverty line for a single individual, about $11,000, for a family of 4, about $20,000, $22,000. And so think about income going up here on the y-axis. On the x-axis, we've got different types of people, if you will, right? So pregnant women, infants, children, aged, disabled, parents, and other non-elderly adults without Medicare or Medicaid. Essentially, kind of think about this last group over here on the right, childless adults, right? So adults without children. So the thing is, historically, states have set their eligibility for the Medicaid program based on all these different groups, and the federal government has said there are mandatory groups that have to be covered up to a certain level of income, and these are shown here in black. But then the incentive to try and get states to increase their eligibility further, cover more kids, more pregnant women, for instance, is the so-called match, right? So the federal government picks up a portion of the spending on the Medicaid program, okay? And so again, each dot here, or circle, bubble, is a state and where they are in terms of their eligibility for the Medicaid program, okay? So that in turn means, well, if you start to think about, well, who are the low-income people who are uninsured and potentially could be targeted best by an expansion of the Medicaid program, it's largely childless adults and to a lesser extent parents, right? So this whole notion of the ACA getting uniform eligibility for the non-elderly population at 133% of the poverty line, that's really targeting the parents and the non-parents, the childless adults. Okay, so what is the ACA going to do, or what was the ACA written to do? And we'll kind of return to how things changed under the Supreme Court ruling. As I said earlier, expanding eligibility for all non-elderly people up to 133% of the poverty line. And so here there's a little bit of confusion for people not really in the know. There's a 5% disregard, right? So 5% of your income would be disregarded. So in essence, we're really talking about covering people up to 138% of the poverty line. So in some sense, like if you're reading newspaper accounts or policy briefs or whatever, it's not a typo that if you see 138 or even 133, right? Okay. So again, kind of reminding ourselves of what the CBO said was going to happen as a result to the ACA, if all states actually did increase their eligibility to 133% of poverty line. This was covering about increasing enrollment in Medicaid from about 35 million up to 51 million, transitioning from about 10% of the entire US population to about 15% of the population, okay? And so I mentioned these matching funds, right? So many people refer to it as the FMAP, the Federal Medical Assistance Percentage. This is basically the split between the federal government and the state government, where for the Medicaid program, historically, the FMAP's been about 56%, with the federal government picking up 56%, state government picking up 44% on average, but the FMAP varies to give more money to low-income states, less money to high-income states. So the FMAP, for instance, for us here in Maryland is 50%, okay? So if we think about these newly eligible people for Medicaid, the parents and the childless adults here, all the way off to the right, the federal government is going to have a very high match fund for them to be covered. So it's 100% for the first 3 years. By 2020, it will be 90%, and it kind of phases down from 100% down to 90% in the years in between, right? So in some sense, this is an expansion financed primarily or almost exclusively by the federal government, with the states in the out years picking up a small portion, okay? So here now is the catch where the Supreme Court thing kind of came into play. Section 1396, parentheses C, right? So you're all familiar with that section, right? Basically said that states not complying with the ACA's Medicaid expansion will lose all of its federal Medicaid funds rather than only the additional federal funding for the expansion, right? So maybe in back to this perspective, the penalty here for a state not going up to 133% of poverty was going to be that all of their federal funding for the populations they cover now would be pulled, okay? So the states, National Federation of Independent Businesses, Paul Clement acting on their behalf, basically made this case, tried to make this case that was coercive, right? And as I said, totally flying under the radar, as a bit of surprise, the Supreme Court, pretty solidly agreed that this was coercive, that placing all existing Medicaid funds at risk is unconstitutionally coercive under the spending clause, right? So a spending clause is a portion of the Constitution that relates to federalism and the federal government giving monies to the states. Okay, so a couple of key money quotes here. What Congress is not free to do is penalize states. What Congress is not free to do is to penalize states that choose not to participate in that new program by taking away their existing Medicaid funding. Separately, spending clause programs do not pose this danger when a state has a legitimate choice whether to accept the federal conditions in exchange for federal funds, right? So basically the argument is like, look, every state's going to be forced to do this because losing all of their federal funds for all the populations they've covered over the last 30, 40 years, that would be too much to lose, okay? So I'm going to turn this over to Lisa in a second, but to kind of set the stage, right? Well, how are the states reacting to this, right? So The Hill, a DC kind of insider publication, had a headline on July 3rd. 15 governors reject or leaning against expanding the Medicaid program, right? So now that essentially the Supreme Court ruling has essentially made this expansion up to 133% optional for states, you see a lot of governors, Republican governors, starting to say that they're not going to do it, or maybe trying to be a little nuanced and say, well, we'll have to look into it, but right now we're thinking of all the costs we'll have to incur because of it, and so on, right? And so the complication here is that if a state decides not to do this, right, Well, the low-income people, right, so particularly the people at poverty or below, are really, really, really like out of luck because the way the law was written, these tax credits for private health insurance coverage in the exchange are made available to people between 100% of the poverty line up to 400% of the poverty line, right? So the way everybody kind of initially envisioned it is all states would go up to 133, and then the tax credits would go from 133 to 400. It was written so that people at 100% of the poverty line would still be eligible for these tax credits. But the thing is, if you make less, right? If you make less than roughly $11,000 as a single individual living in, say, Texas or Florida, and that state's not going to expand Medicaid coverage for you, well, you can purchase coverage in the exchange, but you'd have to pay the full like $5,000 or so premium rather than getting the majority of that covered for you, right? So one thing about like, well, will this really happen? I think politically, you're going to see lots of hospital associations. Actually, we've already seen it. Kind of coming around to their governor and saying, like, are you crazy, right? We're really going to turn down all this federal funding because, like, we're paying for a lot of the things in the sense of lower Medicaid reimbursements, lower DISH reimbursements, and we're not going to receive this federal money for the Medicaid expansion. That's gonna kill us, right? And so again, one last thing to kind of transition over to Lisa is that many people are kind of thinking, well, hey, what's really maybe going on in some of these moderately conservative Republican governor offices is that, well, look, this is a little bit of posturing, right? So we're going to think about this as the first opening bid of a negotiation that's ultimately going to give us more flexibility, right? So Rick Scott, Rick Perry, maybe even Bobby Jindal might just like totally say, no, we're never doing it. But maybe somebody who's a little bit more not so far right for you guys, thinking about trying to use this as a way to negotiate flexibility in the Medicaid program. For instance, something like a block grant. And with that, let me turn it over to Lisa Dubay. If you've come in late, Lisa Dubay is Senior Research Fellow at the Urban Institute, expert in Medicaid, state policy, federal policy. And so she's now going to kind of continue and walk us through what some of these implications of the Supreme Court case decision, particularly with respect to Medicaid, might actually mean. So Lisa, are you there? Oh, brother. Lisa. You guys, Lisa, are you there? She was here, right? So many of you heard her at about 11:55. Oh, do I need? Oh, I'm going to let you.
If you'd like to make a call, please.
Shoot. This screen is totally blacked out for the phone, so I think he might be calling her back there.
Okay, should I?
I think we need to have the connection through
Yeah.
them so that.
Well, so just bear with us, I guess, for a couple minutes.
Yeah. Technology is great when it works.
Yeah. It was working awesome at 11:50. It's like, Lisa, how you doing? Oh, I'm fine. Should take questions to me specifically while we try and iron this out.
Yeah, I don't know. This is totally out. I don't know if that's part of the problem. We could do that while we're waiting for this to work out, if you want to start taking some questions for Brad.
So maybe one thing we could do while we're trying to get so what we were originally thinking is I'd give my presentation, Lisa would give hers, and then we'd open it up for questioning. But this might allow us to do that now. Anybody? No questions? Okay, yeah.
So initially you talked about the core points of the law being the 4 different points where it was Medicaid, state health insurance, the pre-existing conditions, and the individual mandate. And you said that you explained what the Supreme Court's ruling was for the individual mandate and the Medicaid expansion, but what about those other 2 points? Were they?
Oh, yeah. So so the question is, like, when I kind of first went over this discussion of the ACA, its main objectives, the Medicaid expansion, the health insurance exchanges, the non-discrimination by health, and the mandate, it's kind of the question about what were the other 2 elements of the Supreme Court decision. Yeah. So that was kind of, so this was interesting. So yeah, once again, there were 4 specific things that the Supreme Court was going to decide upon. The first is, I can't remember the technical term. There's a technical term for it, but basically it's a rule, maybe it's like a century-old rule, that says if someone's going to bring a challenge to having to pay a tax, they can't actually bring that challenge until someone's actually paid the tax. Okay, so like in plain English, the thing was, well, like, look, no one's actually even paid an individual mandate penalty yet because they're not going effect until 2014. Like, would we have to wait until 2014 or even 2015 to even like decide upon this based upon this like particular clause, the taxing power or something along those lines? And so that was one case, and that was actually what was heard on day 1. And so the thing that's kind of curious is the Supreme Court said, yeah, we're just going to go ahead and make a decision now. This doesn't apply. And I think in large part just because they wanted to make a decision, right? So regardless of like the legal discussion or whatever, they wanted to just go ahead and make a decision and get some certainty here with this. But kind of the interesting thing is like, well, there's a bit of a paradox because like, well, under the taxing power, if you're saying the mandate is constitutional because it's a tax, well, then that kind of means that this obscure taxing provision should mean especially that we'd have to wait until 2014 where somebody actually paid it. But anyway, that was day 1. Supreme Court said, forget that. We're going to go ahead and make a decision. And so now we got 3 left. So the 3 left are 1 is the individual mandate constitutional. And then the second one for the 3 remaining is, well, if the individual mandate is unconstitutional, then what, right? And so interestingly, I guess most legislation includes what's called a severability clause that kind of says, look, if a particular component of this law is struck down by the courts, everything else in the law actually stands. Okay, so the ACA didn't include that, and kind of that's what set the stage for this notion of quote-unquote severability. If the individual mandate gets struck down as being unconstitutional, then what? And really there was kind of a range of options. One is just to say, well, the individual mandate goes, that's it, and then everything else is just going to kind of stand. At the other end of the spectrum, which is kind of consistent with what Florida Judge Vincent decided. Oh, great, Lisa's here. Cool, great. So let me finish a question about real quick about the Supreme Court decision. So there's this range, right? And so it could have been thrown out. And then the real tricky thing was like, well, in the middle, right? Some of the provisions, like the guaranteed issue, the community rating, have a real strong connection to the mandate and could arguably not be severed. Whereas other things like going forward with accountable care organizations or bundled payments in the Medicare program, not so connected. And so there was this kind of issue about, well, what's severable and what's not. Many people, particularly me, would have been really interested to hear what that decision would have been. But the Supreme Court saying that the mandate was constitutional essentially made it moot. Yeah. Okay, so Lisa, you're with us now?
I'm with you. Sorry for those technical difficulties.
Yeah, no.
I wish I could be there in person, but I can't. And one of the, I'll just say up front, one of the challenges of doing this remotely is that I can't see your faces. So if you're looking bored and I keep rambling on, I apologize in advance. I just want to start a little bit by sort of reiterating what Brad was saying, just in terms of how surprised I think people were at the Medicaid decision. And at least for those of us that have been working on Medicaid for decades, the Medicaid expansions for pregnant women and the Medicaid expansions for children were, in fact, just like this particular Medicaid expansion, in the sense that the federal government said, you have to do this, and if you don't do this, we can, withhold any part of your Medicaid program for noncompliance. And while they've never had to do that, the SCHIP program, which was sort of the next big expansion in coverage for kids, was actually completely voluntary. So that maybe should have tipped us off to a sense that states were really not all that eager to expanding coverage, although many, many states have expanded coverage beyond what's the mandatory minimum. So for the most part, I think people that had been looking at the court cases were very surprised that the Medicaid piece was even being discussed by the Supreme Court. At the Urban Institute, we had a little bit of a sense that this was potentially a real issue, because right before the arguments, we got these emails from the Supreme Court librarians asking for this body of research that my colleague Genevieve Kenny and I had done on the Medicaid expansions for pregnant women and children, and we thought, well, that's nothing. But then the Friday before the decision, we got another round of requests for that same, different pieces of that body of research, and so that made us very, very nervous about what the court was thinking about doing with respect to the Medicaid program. And in a lot of ways, it turns out that our concerns were not unfounded. I'm going to talk a little bit about what this means for low-income people, what it means for states, but I think even beyond the Medicaid expansion, there's a real concern, and while I'm not a lawyer, about what this means more broadly for the federal government's ability to make states do things that they want them to do. And they do that in a lot of different aspects, not just health care, but also in terms of telling states they need to have seatbelt laws if they want highway funds, or telling them they have to do a certain thing in their welfare program if they want block grant funds. And so I think this decision will have some implications down the line, and for those of us who care about ensuring that there's a safety net of human service and health programs for low-income populations across the nation. And so that will play out over time. But back focused on the Medicaid expansion piece of the Affordable Care Act, Brad, if you could flip to the next slide. One of the first things we did when we heard about this was, let's try and understand very quickly how many people this affects. And so within 3 days of the decision, we actually put out 3 different briefs looking at who are these people, who are the uninsured, and what are their characteristics. And so the people that are sort of broadly at risk are the uninsured, who could be eligible for Medicaid under 138% of the federal poverty line. So when you look at the uninsured in general, in 2010 there are about 47.3 million uninsured. About a little under half of them would potentially be eligible for Medicaid, either through continuous Medicaid because they're already eligible, or because they're newly eligible. And so if you look at just the 22.3 million uninsured who could be eligible, who would be eligible for Medicaid if all of the states expanded, you get this pie chart. And what you see is about 11.5 million, or about half of them, are newly eligible, people who would be newly eligible adults with incomes under 100% of the federal poverty line. And then there's 3.6 million adults who would be eligible for the Medicaid expansion if a state expands coverage up to 138% of the federal poverty line. But if they don't do that, then they're eligible for premiums in the exchange because their incomes. There was a drafting mistake where instead of being tied to 133% of the federal poverty line as a floor for people eligible for advanced premium tax credits, it was 100%. So there's this 3.6 million people, mostly exclusively adults, who have low incomes between 100 and 133% of poverty, who could actually get a tax credit. Now, this tax credit is going to cost them 2 to 3% of their income. It's not going to have the same kind of cost sharing and protections that the Medicaid program has. And so, if you're a sick person in that category, you'll get an advanced premium tax credit. It's not going to be the same as having Medicaid coverage, and it may be, not technically unaffordable, practically unaffordable for many people. In addition, there are about 2.9 million children who are currently eligible for the Medicaid program but are not insured, and 4.4 million children who are currently eligible for Medicaid, and 2.9 million adults who are currently eligible. And these currently eligible populations are actually the population that states are complaining about, because, as Brad said, there's a very high federal match on the newly eligible population. But for the currently eligible population, the state will get their regular match. Now, this is about a third of the people under 138% of poverty. So that's just sort of a look at sort of where people are. So ultimately, there are 15.1 million people who could have been made eligible for the Medicaid expansion, who could be made eligible for the Medicaid expansion if all states expand coverage up to 138% of the poverty line. So I think it's useful if we go to the next slide, and Brad, if you could click on the link. You can see a picture of these states are. Okay, and if you look at this map, I'm sure many of you have seen it before, but just to be clear, the bright red states are the states that have come out actually saying that they're not going to expand the Medicaid program, and these states are Florida, Georgia, Louisiana, Mississippi, and Texas, sort of that lower swash of the South. And in addition, Iowa, Missouri, Nebraska, Nevada, and New Jersey are all saying that they're leaning against doing so. Interestingly, Scott Walker in Wisconsin initially said that they were not going to expand the Medicaid program, but then there's apparently the public relations people for the state have said they're considering it. And what's interesting about this map is you can go, you can click on the links later on and see that, like if you click on it'll show you the exact quotes about what everybody is saying. So I think that's an interesting, useful little tool. And if you see those sort of the judges weighing symbols, and those are the states that were actually took part in the lawsuit against the federal government. Now, Brad, if you click on the top right-hand part of this graph where it says, look at this by uninsured, what you see is that with the exception of New Jersey and Iowa, I think it's Iowa, most of these states really have very high uninsurance rates, over 20% for most of these states. And So that's potentially problematic. And in fact, if you look at just the states that have said they're not expanding, they account for about 33% of all the uninsured in the country. So these are states that have very high uninsured populations. So if we go to the next slide, one way to think about this is, as states are considering expanding versus not expanding, is what share of the uninsured would be eligible for Medicaid in states that aren't expanding. And so what you see here is, compared to the U.S., in general, these states are, as we said, both have high rate, a large share of their uninsured are actually in the are in the group of who would be made eligible by a Medicaid expansion. So, if Florida wants to solve its uninsured problem, or if Mississippi wants to solve its uninsured problem, just giving tax credits to people is not going to solve most of the problem, because the vast majority, for instance, in Mississippi, more than 60% of the uninsured have incomes below 138% of the poverty level. Texas is surprisingly low, and the reason for that actually is because there's a large share of the uninsured in Texas, or a larger share than in other states, are undocumented immigrants, and they're not included in the potentially eligible population. New Jersey is another place which is actually a high income state, which is why the share is so low. So as you can see, states are not, if they're interested in solving their uninsured problem, not expanding the Medicaid program is going to be particularly problematic. And if we go to the next slide, you'll get a little bit of a sense of what Brad was talking about in terms of the rates. And so these estimates actually come, again, for the states that are not expanding or leaning towards not expanding. The share of this is based on a simulation model done by some colleagues of mine here at the Urban Institute. And the blue represents the increased Medicaid spending on actually not newly eligible adults, but on eligible adults in the Medicaid program over the first 6 years of the program. And what you see is that the vast majority of these expenditures are paid for by the federal government. So, it's really a bit of a quandary to many people as to why states wouldn't take advantage of this huge infusion of federal dollars for just a very small input of federal costs. And in fact, nationally, about 95% of the costs are being covered by the federal government. And that's not a different picture in these particular states. You go to the next page. So I think it's a really important question to think about is, why aren't states expanding? And I think, in defense of the governors who are really seriously considering whether or not they're going to do this, I think there is a real concern about the financial costs of the state share of the program. And, while there's a 100 to 90% match on the newly eligibles, states have really been concerned about the current eligibles participating in the program. When we do our simulation models, we don't think that a lot of them are going to be enrolling. They've already had a chance to enroll. They haven't taken it up, although some may. But I think that is a real concern for states. There's also a concern, I think, also potentially, probably not well founded, which is that what's going to happen, after the first 10 years of the program, and will the federal match decline? But I think there's also sort of a little bit, as Brad alluded to, some pretty serious political posturing going on. There was the Republican governors actually sent Secretary Sebelius a letter asking a number of questions now that the Supreme Court ruled on the Affordable Care Act. And from that, what you can really glean about sort of where they might be going in terms of bargaining for more flexibility from CMS, because they asked some relatively pointed questions. First of all, I think many Republican governors are eager to receive block grants, and while the advantage to them is the great flexibility and ability to be more creative and more streamlined, if you look at the Paul Ryan budget plan for Medicaid, by 2022, states would see about a 30% reduction in federal dollars out of the Medicaid program going to the states. And so it's not clear to me that that flexibility would buy them that kind of a reduction. In addition, it would, there's a call for, just eliminating the Affordable Care Act in general. I think what may be more likely, perhaps in some of the moderate Republican states that are thinking about not going, is it sets them up for the potential use of waivers, and specifically in the governor's Republican governor's letter to Secretary Sebelius, they asked about things like health savings accounts and personal responsibility options for this very low-income Medicaid population, which I think is potentially problematic for people at that income. There's also has been at least one state who has asked about the maintenance of effort. So basically, the Affordable Care Act required states to keep their Medicaid eligibility rules the same as they were until 2014 for adults and until 2019 for kids. And at least one state has asked for that maintenance of effort to be reduced and eliminated, allowing them to reduce their Medicaid eligibility threshold, and has threatened to, a court challenge to if the federal government tells them they can't do that. So I think there is some flexibility that some of these states are angling for. And, what's interesting, too, is that one of the law in 2017 allows states to have a lot of flexibility. President Obama has, asked Congress to make that available to states earlier from the beginning of the program, but there's been no action on that. So I think there's some real political posturing that has to do with making the Medicaid program more flexible and more keeping with some of the governor's sort of Republican market types of programs. But then I think there's also just the fact that it's an election year. They're walking lockstep in their dislike of the ACA, and seems like many of them have been or were considering being president or vice president. So I'm not going to rule that out. So if you go to the next slide, I think the posturing about what the Medicaid program would cost the states is a little bit unfounded. I mean, another piece of work that was done by the Urban Institute suggests that nationally states will spend about 92 to 129 billion less over the 2014 to 2019 period if they fully implement the Affordable Care Act rather than not implementing. And that those savings come from a bunch of different places, including reductions in uncompensated care. And in addition, there will be, regardless of whether or not a state expands Medicaid or not, huge reductions in federal disproportionate share hospital funds. And also, there'll be reduction in state mental health spending, which leads to this sort of reduction, this overall national reduction that you see. We're right now doing some more estimates to look at that with respect to what happens if you don't expand the Medicaid program. Those results are not out yet, but will be coming soon, we hope. But at the same time, I mean, I need to say that for some states, the additional dollars could potentially be problematic. The other thing that people are talking about is what's called the multiplier effect of additional federal dollars flowing to states. And CBO, in analyzing the effects of the stimulus plan, estimated that the multiplier effect is between 7 and 1.8% of the actual investment. That is, this huge infusion of federal dollars into the states will have economic benefits to states that go beyond the actual dollars in terms of generating output. So I think the real analysis of what the cost really is to the state minus the offset has not been really done in many states, and although, but I think many states are starting to tackle this right now. So Brad, if you want to go to the next page. So who loses if the states don't expand? One of the briefs that we're hopefully going to put out in the next week is to look at who are these newly eligible populations. And in general, they're mainly the lowest income, most at-risk people in the state. And by not expanding Medicaid, these folks are not going to have access to affordable care coverage. Contrary to what, sort of the word on the street is, these are not just a bunch of young, healthy kids. There's really a broad age distribution in terms of these people who would be newly eligible, although they're disproportionately under age 35. There are, many older people as well. The vast majority of them are childless adults, and that is completely related to the picture that Brad showed before, which showed that most children in this income group were eligible. In fact, all children in this income group were eligible prior to the Affordable Care Act, and parents were covered to a lesser extent than children, but certainly much more than childless adults. So you have both, childless adults who are young, and then you have childless adults who are old and who have children that have grown up. The majority of the folks are white, although this varies a lot by state. And most of them there's a large share of them have income below 50% of poverty. So you're really talking about a very, very vulnerable population who stand to lose the only potential access to affordable coverage that they have. So that's just a little bit about what are sort of the potential downfalls of not expanding. But so there's really, there's the good news is that most of the states actually either have not made a decision, are leaning towards expanding, or not leaning towards expanding. And I think over time, all of the states will expand coverage. And so you can move to the next slide. I just want to give my spiel about, in states that do expand, there is so much work to do to get these systems up and rolling. There are many administrative challenges to developing a seamless enrollment system where families can smoothly transition from Medicaid in exchange as income and circumstances change over the year. When I was at HHS, this is an issue that I spent a lot of time working on. I think the consumer navigation and education will be critical. I want to go back to Brad's sort of E-Trade analogy, because the people that are going to be going into the exchange at the beginning of the year are really going to be betting on what their income is going to be over the end of the year. And if they bet wrong, they could, end up owing money back to the IRS at the end of the year. And so I think for people out in the field, really developing navigation and education is going to be critical to making, this whole system work well for low-income individuals and families. And I think one of the challenges to doing that, in addition to sort of getting you in the right program at the right time, is having plans that can operate in both programs. And I think that's going to really vary by state. It's going to be potentially problematic in states that have a federal exchange. But I think to the extent that plans can operate in both programs and people can more seamlessly move between plans, I think that's going to be a big challenge for making this whole system work. So I'm going to stop there.
So thanks, Lisa. Let's see. So I think we've got about 25 minutes left for Q&A. We've got 2 mics here in the room. So actually, yeah, if you could wait to have a mic get to you. And then for those of you who are watching at home or watching in your office, I believe there's a link for you to click and type in a question, and that in turn will get Molly Mitchell here able to ask it verbally. So
Great. I think the mic works.
Oh, yeah.
So thank you very much. Some quick questions about really what this is going to look like in the ground in Maryland.
Okay.
When you're thinking about the exchanges that are being created, is that like a different form of Blue Cross Blue Shield or something when you're thinking about billing? And then also, too, my understanding is in some of that 2,000 pages of the Affordable Care Act, there are like benchmarks and 30-day outcomes and stuff like that that ties into funding. And is there anything like that that we're particularly concerned about in Maryland?
Let's see. So for Maryland, so interesting. Like big picture, I mean, Maryland was like right out of the gate saying we're like a enthusiastic supporter of healthcare reform. I think Martin O'Malley had an executive order the day after the ACA passed. And Maryland has been like at the forefront, probably with just only 2 or 3 other states in terms of getting this implemented. And the thing is, like if you talk to Josh Sharfstein or other board members, or maybe Rebecca Pierce, who's the executive director, like they're a little nervous about whether it's really going to like come together. I mean, I don't think any of them have any doubts that it'll come together, but it's stressful. I mean, they've got a ton to do. And, Lisa referred to some of these challenges about getting the computer systems to talk to one another. But Maryland will get there. But if you think about all these other states that have just kind of languished, either because they're eventually going to do a state exchange, or maybe they're just, out and out saying like, no way, no how. And then the federal exchange will come in. It's going to be an interesting year and a half. So as far as like what this might look like in Maryland, okay, so Maryland has made a decision to essentially run 2 different health insurance exchanges, one for individuals and one for small businesses. The small businesses one has an acronym SHOP. And so the way this would work is the state exchange has a board of I think 9 people, and they're gonna hiring lots of staff to kind of set this up. Imagine that what they're doing is kind of setting up a website like Travelocity or Kayak.com or something along those lines to enable people to shop among different health insurance plans. So if you think about the health insurance landscape here in Maryland. Care First, the Blue Cross Blue Shield plan, really is a dominant player in Maryland. And so the thought here is like they're not actually setting up the exchange. It's the state that's setting up the exchange and in turn allowing people to pick Care First versus say United versus say Kaiser. And the hope really is that the website will be functional enough to allow people to shop or sort by premium, sort by quality ranking, sort by cost sharing parameters, and so on. And then behind the scenes, getting the tax credit subsidies calculated so that the premium you see is essentially your net premium after the tax credit. Let's see. So I think you had a part of your question was about 30-day readmissions.
What outcomes are they using to manage their funding that's latched on to some
Yeah. So along these lines, I think as far as outcomes go, as far as quality measures, I think the general principle here is that you go to the exchange and you'd be able to see some kind of like star rating or something, some kind of score that allows you to get a sense as to like the quality of that plan, right? So compare Kaiser's quality versus Care First, and there's an acronym HEDIS, so NCQA, National, I can't even remember, but there's like nonprofit agencies that try and come up with these quality scores that use a whole bunch of metrics, like maybe some things like readmission rates or patient satisfaction, that kind of stuff. So at one end of the spectrum, you can imagine the exchange saying, look, we're just going to collect this information and we're going to put it on the website and let consumers make a choice, hopefully an informed choice about what kind of plans they want. At the other end of the spectrum, you can imagine some exchange boards being more proactive and being what's sometimes referred to as an active purchaser, and saying things like, Care First, you came in with a premium quote that we think's too high. Like, try again, right? If you want to be on the exchange, or with this notion of quality, right? So, hey, insurer that we've never really heard that much about before, we're a little concerned about your quality ranking. We don't think we're going to allow you to be on the exchange. And so here too, I think you'll see lots of like variability across states in terms of what they'll do.
Similar to when, say, I'm an employee of the School of Medicine and I choose if I want Care First or EHP or blah. That's what the exchange is essentially looking like.
Yeah. So in some sense, yeah. I mean, the simple way to think about this is that for the vast majority, so I think especially like probably listening or in this room, like our private health insurance works like pretty well, right? So Hopkins offers us a number of choices. We've got really talented HR specialists that come up with these plan options for us, and we have a choice. We may gripe about the fact that we're paying a lot, but besides that, life's pretty good for us. The general intuition is to think about the way private health insurance works for us in the large group setting, and transfer that over to the individual or small group market. And in some sense, those two markets act very differently. So like the individual market, like you're kind of bewildered by the vast amount of choice that you have in terms of all the different plans. You're also like potentially discriminated against in terms of your health status. Maybe you won't get a plan. But as far as the small group market goes, if you're offered health insurance, it's generally the case that you're just offered like whatever your employer picks. So looks like Molly's got a question, yeah. And then we'll get, oh.
We have a few questions from our online audience regarding how this is impacting the state and local health departments, both here in Maryland and nationally. What kind of funding has come to the state and local health departments and how this might impact them?
Yeah. Lisa?
I don't have a good answer to that. I think my guess is that would vary by state, but I think I'm just going to not say anything.
Yeah, so I need to plead ignorance on this one too. I mean, I think some of what you could imagine a lot of these local agencies doing, whether it's a government agency or even just kind of like a nonprofit consumer advocacy orientation, is trying to take on this notion of like the navigator role and help people navigate their choices on the exchange or help them get into the system as far as Medicaid eligibility goes. Now, as far as other like public health spending, right? So there was in the ACA a chunk of money. I forget the actual amount in billions, but a large chunk of money to go into like a prevention fund that in turn would be used to kind of dole out monies for various initiatives. And I think that's rolling along. And I think a lot of that money is certainly filtered down, but it's also been a big target for Congress, particularly the Republican Congress, to cut that prevention fund in the future. Yeah. Should we go? Yeah.
The other thing I would just add.
Yeah, go ahead.
Oh, yeah, the other thing I would just add is that there's certainly a very high federal match. I think it's 90-10 on IT infrastructure building to help states get their eligibility enrollment systems up. And so my guess is that that's sort of how that those dollars are distributed will probably vary by state, but in many states, some of that probably is going to the local health department to the extent that they're dealing with any of those enrollment systems themselves.
Yeah, definitely. Yeah.
Hi, thanks. Is this working?
Yeah, you're good.
I was just wondering if you could briefly go over the process for actually making a decision of expansion, like the legal process, because I know some of these states where the governors are either conservative and have said that the legislature might not match, right? And so I didn't know how that affects the actual outcome of whether they expand or not, and then whether, I thought governors might have an executive order. I just wasn't quite sure.
So,
Go ahead, Lisa.
so my understanding is that most states have something that built into their legislative process that gives the governor the ability to comply with federal mandates. Now, so that presents a big problem now because there's no federal mandate. So I think this is going to really vary by state, but I think my guess is that both governors and legislatures will have to be in a place where they're supportive of this for it to happen.
Yeah, because to follow on to that, I think there'll probably be interesting situations where maybe like the governor is doing a lot of posturing about not wanting to do it, but the state legislature may collectively want to do it, and then you could, I guess, imagine the potential for state legislatures passing laws saying, yes, we are going to indeed like do the Medicaid expansion, and then potentially have to worry about like a governor veto and all those kind of things.
For example, one other example is that Ohio in 2010 has an initiative on their ballot prohibiting the legislature and the governor to implement any aspect of the Affordable Care Act. So that's sort of sitting out there right now.
Mm-hmm. Other questions? Yeah, we got you've got one right there.
Yeah, given that, regards to Medicaid expansion, given that Maryland tends to be progressive in healthcare matters, could we anticipate that rather than wait till 2014, they'll begin ramping up over the course of 2013 in enrollment in Medicaid?
So I can do this. So I think the short answer to that is they certainly could, and so there is indeed money available in the ACA for a state that like wanted to cover its like childless adults in advance. I don't think anyone in Maryland has been talking about doing it in 2013 early, and instead waiting to 2014.
I was thinking of all the PAC patients we have out there.
Oh yeah.
Just sitting waiting for it to happen.
Yeah. No, right. So I would imagine as an observer that PAC is just gonna carry along over the next year and a half until in 2014. Now, so I mean, to the state's credit, right? We had a very, very big Medicaid expansion in the state as a result of, I think, like a 2007 law, right? Maybe implemented in 2008, 2009, that took parents up to 116% of poverty, right? So in some sense, like we here in Maryland, like as a progressive state, have actually been ahead of the curve in terms of covering adults in the Medicaid program. And so if you think about the uninsured in Maryland who are largely going to gain coverage through the expansion up to 133, it's the childless adults. Now, this may be a little bit unpopular to say, but in some sense, like Maryland's in some sense kind of punished by being a progressive leader because the funds off into the future to cover these parents up to 116% of poverty line, it's a 50-50 split between the state and the federal government. And so if we had actually not passed that Medicaid expansion and stuck with just 50% of poverty or so, we would have gotten a whole lot more federal money because that whole population would have been newly eligible.
I think
Go ahead. Yeah.
Yeah, sorry. There's a delay on the screen from me
Okay.
seeing you, so I'm sorry if I'm jumping in. It looks like you paused. I think that this is part of, ultimately ends up being part of the trade-off that the president made with the American public of most people will keep the insurance that they have in addition to these additional benefits. So I think, it's certainly true that the ERISA plans, the self-insured plans, currently now offer greater benefits potentially. I mean, certainly than what's being offered, going to be offered in the exchange, but over time we may see an erosion there as well.
Other questions? Yeah, over there. Yeah.
Yeah, quick question as we round up.
I'm sorry. Yeah.
Sorry. I just wanted to find out the other side of the story is whether with the passage and implementation of this law is going to do anything to the cost curve as we go forward, whether it's the general healthcare cost curve or even for the S-chip or the Medicaid.
So maybe I'll take my first crack on this, and I suspect I might be more pessimistic than Lisa. I'm not sure. So I mean, my general feeling on this in terms of healthcare costs in the U.S. being really, really high and increasing over time at a really high rate. Frankly, I don't see a lot in the ACA that's really going to change that fundamentally, at least for sure, right? So in some sense, and I think those of you who maybe have taken my course, U.S. healthcare system, you kind of realize just how fragmented and dysfunctional our current healthcare system is right now in the U.S. Like very complicated with all sorts of different payers, and rather than try and like wipe that away and build a new system that's a lot more functionable and streamlined and efficient. Instead, we've really kind of built, the ACA is building on the current healthcare system, which I would kind of argue like has a bit of a shaky foundation. And so I think as a result, there probably isn't a whole lot in the ACA to really kind of like fundamentally transform the system into something that's a little more efficient. So two caveats to that. One is just politically, like doing something that kind of wipes away and gets a new system in place that's a lot more efficient, like impossible, right? So as Lisa said earlier, I mean, for the president to be able to say, if you like your coverage the way you have it, now, nothing's going to change. Like, don't worry about shaking the apple cart. I mean, a lot of people are pretty satisfied with their health care, and talking about doing a fundamental change would have gotten a lot of people scared. And probably would have really damned healthcare reform, kind of like what we saw with Bill Clinton in the 90s. So in some sense, yeah, I can criticize the ACA about being dysfunctional or whatever, but at the end of the day, it was healthcare reform that actually passed and is going to cover about 2/3 of the uninsured. So it's a good thing. The other caveat I'll say is that, well, the ACA actually does have, like, part of this like 2,000 page law has a lot of like elements that are trying to be pretty innovative, right? So here in Baltimore at a new entity called CMI, Center for Medicare and Medicaid Innovation, and other aspects of the ACA, they're really going to try and implement or try these little pilot programs to tweak the way payments are made, tweak the way that providers are organized, emphasize, primary care, medical homes, a lot of things, a lot of little experiments where some of these things may not pan out, but hopefully some of them will. And that in turn can maybe lead to lessons learned so that over a longer time perspective, maybe there are some changes that can be made. So Lisa, yeah. Go ahead, Lisa. Yeah, yep.
I think one of the big challenges is that we don't, within the current system structured like it is, we don't know how to tweak it necessarily. And so I think one of the things that's great about the Affordable Care Act is that there are these demonstration projects. There's a huge, okay, Senator Rockefeller is not really happy about this, but there's a huge demonstration program that's going on in up to 25 states where trying to integrate Medicaid and Medicare coverage for the dual eligibles. And similarly, there are medical home demonstrations and there are quality demonstrations. And I think trying to understand how we bend the cost curve while maintaining quality in this system is an open question. And hopefully we'll learn what does and doesn't work from some of these demonstrations. At the same time, Senator Rockefeller's concern is that we're putting, the dual integration program is that we're putting our most vulnerable citizens in an experiment, and maybe we should move more slowly. But as one of the evaluators of that, it's you can see why he wants to do that.
Yeah. Well, that's where all the money is. Yeah. So maybe with that, I see we're at 1:30. So thanks to you who stuck it out to the very end. Really appreciate it. Molly, do you have any words to say?
I just want to give a big round of applause and a thank you to Brad and to Lisa for their
All right. Thanks a lot. Thanks everybody for coming.
Okay,